Hello, and welcome to a special edition of Cancer Speak. I'm your host, Dr. Suresh Ramalingam, Editor-in-Chief of Cancer and Executive Director of Winship Cancer Institute at Emory University. Today, we are diving into key highlights from the 2024 European Society for Medical Oncology Congress, which was held this past September in Barcelona. The ESMO Congress is one of the most influential oncology meetings in the world, bringing clinicians, researchers, and patient advocates together to share the latest findings in cancer research and treatment. Today, I'm excited to be joined by two members of the cancer team, both of whom attended ESMO in person. First, we have Dr. Gil Morgan, our social media editor for cancer, and Gil is also a prominent oncologist in the European community. Gil, welcome. Could you tell us a little bit about yourself and your role during ESMO?
Great to be here, and I am the director of OncoAlert, a network of oncology professionals committed to distributing and amplifying reliable oncology information to colleagues worldwide. So by colleagues, I mean oncologists, surgical, medical, and radiation, cancer scientists, oncology nurses, and of course, patient advocates. So we actually at ESMO had a great time. It was a beautiful setting, and of course, OncoAlert faculty were there actively reporting on all the major scientific developments in real time. And this was especially helpful for those unable to attend due to financial or time constraints, or for those looking to reduce their carbon footprint. So in addition to the live updates on social media, we published even a daily newsletter summarizing the top trials and even launched a podcast, which was actually a lot of fun. So very happy to be here and doing another podcast.
Thank you, Gil. I would like to mention to our listeners that OncoAlert is an official partner of the American Cancer Society journals that include Cancer. Next, we have Dr. Jason Luke, who is a section editor for melanoma and skin cancers in our journal Cancer. Jason, welcome. Please introduce yourself.
Well, thanks so much. I really appreciate the opportunity to join today and participate. I'm Jason Luke. I'm a medical oncologist at the University of Pittsburgh, where I'm the Associate Director for Clinical Research at the Hillman Cancer Center. And my research interests are predominantly in early phase drug development, but also in the management of patients with skin malignancies and melanoma. And I did have the opportunity to present two different oral abstracts at ESMO, and we'll get the opportunity to talk through them a little bit later.
Thank you, Jason. And last but certainly not the least, we're honored to have Deborah Collier with us. Deborah is the founder and president of Patient Advocates in Research, and she brings an essential patient advocate perspective to this conversation. Deborah, thank you for joining us today. And please tell us a little bit about yourself.
Thank you, Ram. I'm happy to be here. In my life skills before cancer, I was a regional manager and then director of training services in a tech company when I was diagnosed with my first cancer. And this led to getting involved in action-oriented patient advocacy. We actually learned from the AIDS movement. And since 1996, I've been the founder and president of Patient Advocates in Research, which is known as the PAIR Network. And it's an international communication network of patient advocates who are involved in research. And our tagline is to help research meet reality. So we bring patient relevance into translational, preclinical, and clinical research, as well as epidemiology, patient preference and experience research, and healthcare delivery research, working with academics, governments, many scientific and clinical fields, and of course, patient communities.
Well, Deborah, thank you so much for your work that helps amplify the patient voice in cancer care and research. Thanks again to all our faculty members for being here. Let's get started. Gil, OncoAlert is a prominent voice in the oncology social media community, and that's even more so during major conferences like ESMO. Tell us a little bit about your experience at this year's meeting. What did you feel were some of the key highlights of the ESMO Congress?
Thank you, Ram. Well, we are incredibly fortunate that colleagues worldwide trust us as a reliable source for oncology news, and we take that responsibility seriously. So our goal is to ensure that those that couldn't actually attend don't feel disadvantaged, so that they feel that they're still receiving the same information in real time. So the most special moment for me during ESMO 24, besides all the great oncology, was the OncoAlert 5K. And this was our second 5K that we did. The first one we had at ASCO. We had over 100 people participating. And what made it even more meaningful was the event actually raised money for 5 new OncoAlert fellowships that go to colleagues from low and middle income countries, bringing us to a total of 11 OncoAlert Catalyst fellowships that we have offered this year. Now, as far as my oncology highlights, they both came back to back from the presidential sessions in GU Oncology. So this was Saturday and Sunday. The first of a lot of outstanding presentations, but to me, the first one that comes to mind was by my dear friend Tom Powles, who shared results from the Niagara trial in bladder cancer. And this showed that perioperative durvalumab combined with neoadjuvant chemotherapy significantly improved event-free and overall survival in patients with muscle-invasive bladder cancer compared to chemotherapy alone without increasing severe adverse events. And my second pick was a Peace 3 trial presented by another close friend, Silke Gildeson, and the study demonstrated that adding radium-223 to enzalutamide significantly improved radiological progression-free survival and interim overall survival in men with metastatic castration-resistant prostate cancer. So both trials brought excellent news for us and for our patients, and that was just a small part of the excitement for me out of Barcelona, with loads of great data and many concomitant publications.
Wow, great to hear about those two studies. It sounds like they're both likely to change clinical practice. Is that a fair interpretation of the data that you saw and heard, Gil?
I think so. I think that definitely for Niagara, and I think Peace 3, we're just waiting for the next update, but definitely game changers.
So when you see game-changing abstracts presented at this meeting, talk about how you're leveraging social media in making sure that everyone is able to learn about these data and apply them to their clinical practice, even though they could not participate in person at these meetings.
Well, I believe that social media plays a significant role, and I see it as a collegial responsibility. So while we're fortunate enough to attend these meetings and seeing this potential practice-changing data, by posting and amplifying the information, we can share it in a way that those that can attend, they can also implement that information. So beyond that, social media fosters the exchange of diverse viewpoints, and this is something that I like the most because before, I think in the early days of social media, everything was very positive and congratulatory. And now we're getting to that second stage where people actually are starting to have comments on specific trials. They're able to raise questions on specific trials. And although it might not be agreements all the time, it's always in a collegial manner. So I think this is the really great thing, especially when we start using the word praxis changing, because there are a lot of colleagues out there that definitely bring up great points on whether these are practice changing or not.
Great. Thank you, Gil. I want to bring you in, Jason. You were at the meeting. You presented some important abstracts at the meeting related to melanoma and immunotherapy. Talk to us about those studies.
Well, thank you very much again for the opportunity to review these. I had the opportunity to present two oral abstracts. One was an update, a longer-term update to a phase 3 clinical trial in melanoma, and the other was the first disclosure of clinical data of a novel immunotherapy that we're developing. So for the former, what we presented was the 4-year update with the crossover from the Keynote 716 clinical trial. That's a clinical trial looking at the utility of anti-PD-1 immunotherapy with pembrolizumab in earlier stage melanoma, so stage 2B and 2C melanoma. And those are patients who present with deep primary lesions but not nodal metastases. And this is a trial actually that I designed about circa 2015, and it took many years to get going, but now has led to a new standard of care and is quite gratifying to see now as given to patients in clinic. But just to summarize it quickly, what we found was that at 4 years of follow-up, we now had quite stable hazard ratios or benefits for recurrence-free survival as well as distant metastasis-free survival, showing roughly speaking a 40% improvement out over time for giving immunotherapy as compared to a matched placebo. And for the first time, we also showed what's called progression or relapse-free survival 2, which means what happens to the patient when they go on to their next line of therapy, which also showed a 25% improvement. And we presented for the first time the numbers needed to treat in order to see a benefit for an individual patient, which for adjuvant therapy is always an important consideration when you have to challenge the benefit versus the potential side effects, of course, of giving treatment. And those numbers were 5.3 patients treated to prevent a recurrence and 7.8 for preventing a distant metastasis. And so we think these are very, very important data to inform the field. We think that there's a major benefit to giving adjuvant immunotherapy, even in this what was previously considered earlier stage melanoma population. And we would advocate that all patients be offered the opportunity to take anti-PD-1 with pembrolizumab or nivolumab, actually, which is also approved in that setting. So that was the first abstract. But by contrast, I had mentioned before, I predominantly do early phase clinical trials work. And I also presented data on a new drug, which was an intravenous administration of a STING agonist. And the drug is called dazostinag, or TAC 676. And so this is a novel area of drug development. STING is a very important sensor in the immune cells for self versus non-self. Going to the question of how does the immune system know that the cancer is actually present? And the way that that's canonically understood is that human cells have the ability to sense non-self nucleic acids, and particularly DNA, and then trigger immune responses thereafter due to that observation. And STING is the protein that really mediates this. So without going into the nitty-gritty of, phase 1 data, what I would say is that we were able to determine multiple safe doses with the preliminary suggestion that some patients can derive a very significant clinical benefit despite having had progression on all prior therapies. And perhaps most importantly, quite a bit of biomarker analysis trying to look at the translational impact of giving this treatment were contained in the presentation. And those are really important in early phase trials to try to sort out, are we really having the effect in the patient that we're really looking for? Because these, unfortunately, are often patients who have tried almost every other possible available treatment, and trying to see treatment response in these patients can be difficult. While we, of course, hope that's what we see in every patient, making sure that the drug is doing the thing that we think it is so that we have confidence to move it into later line clinical trials is always quite important. So I'd summarize this by saying that the IV STING agonist does look promising and is moving into expansion cohorts in earlier lines of therapy, both for head and neck cancer and for colorectal cancer. So again, thank you very much for the opportunity to kind of review those. I think it's two sides of oncology drug development, one in the phase 3 setting, one in the phase 1 setting, but again, emphasizes why a meeting like ESMO is so important, because it really encompasses all of the kind of research that's going on in the field.
Thank you, Jason, for sharing those exciting developments. I have two follow-up questions for you. One is just learning about the STING agonist. Do you foresee this being used as a single agent, or are there combination approaches that are being considered already?
That's a very good question. It's always one in drug development that we think about very early, especially in immunotherapy. And so going to the mechanism of STING agonism, I think it's hypothetically possible there could be situations where there might be a monotherapy role, but much more likely is it probably will be combined with other kinds of immunotherapies. So all the listeners will know that anti-PD-1 immunotherapy is now a standard of care in many different kinds of cancer. And the underlying biology of anti-PD-1 response is the presence of an immune response that you can reinvigorate with anti-PD-1. Well, of course, then in patients who don't have an immune response, then we have a big problem. And that's why anti-PD-1 for them, doesn't work in some patients. And so you can imagine here a great role for combination using a STING agonist to trigger immune responses that could then be enhanced with anti-PD-1 immunotherapy. So to your point, probably the future is mostly in combination.
Thank you. My second question is just, I'm still processing the data you talked about in early stage melanoma, where now we're seeing highly effective treatments that have the potential to improve the likelihood of cure for patients. How is this translating into practice? Are we diagnosing more patients with melanoma with earlier stage disease as opposed to finding out they have metastatic disease? Tell us a little bit about that particular point.
And so in melanoma, it's a kind of cancer that really spans all of medicine, actually, from very early detection even to late stage disease, of course. So the vast majority of people are diagnosed with stage 1 melanoma, and everybody would recognize that already. You go to primary care or dermatologist and they pop something off the skin. And that's, roughly 50% or more of melanomas that are diagnosed. But as the melanoma on the skin becomes deeper, that's where we get into stage 2B and 2C that I talked about. And that's roughly 15% of melanoma. There can then be, of course, higher stage disease. Stage 3 is involving nodes. That's another 15%. And about 10% of people are diagnosed de novo with metastatic cancer. So fortunately, the incidence of melanoma is actually going down with better, society-based precautions around sun exposure. So that's a good thing, but it has still left this problem, which to date, these patients who had relatively high-risk primary lesions did not have access to treatment, essentially for FDA regulatory reasons. And that's what this trial really, aligned. So it isn't so much that we're diagnosing more patients, but rather that we're now able to offer this therapy to a pretty large chunk of the population who previously just didn't have access to it. And so I think that one point that you're alluding to is these systemic therapies are moving earlier and earlier in melanoma. And I think that point is actually very well taken. And so melanoma, when I started my career 15 years ago, was a surgical disease because we didn't have treatments for it. And now it's almost like that's completely flipped over because we're now giving neoadjuvant treatments. We're giving adjuvant treatments to people with early stage disease. And that's really because immunotherapy in melanoma is so remarkably effective. And so I think we'll only see more of that, especially as biomarker integration can really help us understand who is truly at high risk, even in early stages of disease. And that's where the next generation of clinical trials is going.
It's amazing to hear these developments. I remember the days where melanoma was a highly lethal disease, and now we're talking about curing a high proportion of patients. As we talk about this, I want to turn to Deborah. Given the exciting data you've heard Jason talk about and Gil talk about, Deborah, talk to us about the patient perspective. How do you view these developments affecting patients, and what should we as physicians be doing to communicate these advances to patients better?
Well, that is a very good question. First of all, let me say a little bit about each of the studies because they're both promising in different ways. As far as the keynote study for the stage 2 melanoma patients, more time free of cancer is always reassuring. And it's important that this study looks like it's increasing the number of patients even more who can be treated with adjuvant pembro for stage 2 and stage 2B and C. It does seem to offer a treatment that's different or changing, as Jason said, in how it's given and who's involved with the patient than traditionally higher risk patients. That means that there need to be more communication approaches, better plain language kind of information about explaining what these advances are, where they came from as clinical trials, because people don't know a lot about clinical trials. And this is a way for us to help people learn more about what research is about and why that's important. RFS and DMFS, both as recurrence-free survival and then distant metastasis-free survival, are very promising. But the real measure for patients is overall survival, of course. And so we'll need to wait for those results. And that will be important to give these kinds of information all along the way so that people understand that it takes a while for research to actually find the things that we want to find. I do have a couple questions, though. And one was any patient experience research like PROs or patient preference or anything like that included? And if not, why not? And then there are other things I noticed, like the MIA calculator that's trying to predict RFS and OS. How would something like the results that we're finding and continuing to find with this study be able to improve things like those risk calculators and things like that? Because risk, of course, is the thing that cancer patients are the most concerned about for recurrence.
Yeah, those are great questions. We did include patient-reported outcomes in Keynote 716, and in fact, I've already published them. So I'd point people to that previous work, which was in the European Journal of Cancer, which did show an improvement in quality of life for patients who were on the trial relative to those that weren't. And noting the side effect profile of pembrolizumab, being very well established and generally speaking, not leading to a big detriment, I kind of presume that's actually due to patients having a greater sense of satisfaction or less concern about their long-term outcomes by being on treatment. So in that regard, we were very sensitive to that. And I think that's an important consideration for all large trials, is to bring in the patient-reported outcomes to be cognizant of that. For your second question about risk calculation, I think you hit on the head probably the most important issue that we're now facing in adjuvant management of melanoma, which is that we have quite effective therapies, relatively speaking, but we still overtreat the majority of the population. And so how can we better select people? So the risk calculator from the Melanoma Institute of Australia does look to be a useful device. That risk calculator was generated after we had actually already completed accrual on this clinical trial, so we wouldn't have had the opportunity to use that. But I do think that using tools like that in the future to integrate them into adjuvant trials would actually only help everyone. It would speed up clinical trial participation and really focus the population of patients who are most likely to benefit from the treatments. And then even more than that, there are multiple ongoing efforts now to try to integrate risk calculators with molecular biomarkers. So could we take a piece of the tumor, do, say, gene expression profiling, and then also match that to the clinical characteristics that we know would increase the risk? And by that sort of an approach, could we better optimize the population of patients who we might expose to adjuvant therapy, where we, of course, hopefully would have the biggest impact? So I think the points you're raising are right on point to where the field is thinking, and I think incorporating these thoughts from the patient perspective are going to be essential as we move forward.
So as we talk about the early phase 1 dose escalation study with Dazo, it looks promising, and that's a good thing, especially in patients that have more than one lines of treatment, and a couple complete pathologic responses, I think, were in it as well. I do have to say that if we can get away from the 3+3 dose designs, that's better, because it's better for patients, and it's actually better for sponsors and for the results that we're looking for. And there are lots of different techniques now that can be easily really incorporated. But with that in mind, I think yours was a modified design. Stable disease is also really important for patients that have 3 or more lines of therapy. So it's always good to make sure that we're understanding that. So it was good to see that information as well. And I guess I would just say to everyone that it is important to use as low a dose as we can and still see response so that people are able to maintain a good quality of life, a good balance, and are also able to participate in new clinical trials that will come up. That's one of the fears and concerns for people in clinical trials is what are they going to be excluded from in the future if they need additional treatment and possibly looking into different clinical trials. And we also need input from patients in different settings, including early trials. So that's one that I'd like to know more about, if there's a way that you see incorporating more patient input into phase 1s and phase 2s. And you did mention combination therapy. I think that makes a lot of sense. But as we do that, we also need to remember that we need to be cognizant of the costs and the additional costs that can be there for patients who want to receive those treatments. And that is, of course, a major issue for many people.
So I really appreciate those comments. I think you hit on a number of very insightful points. Maybe to just pick at a few of them, your comments around designs for optimization of dose finding in phase 1 clinical trials, I think is certainly an area that the field is shifting in. I completely agree with your perspective about 3+3 designs. This study did have a slightly more nuanced element to it, which it did have a Bayesian logistic regression model that enhanced the toxicity profile in each dose. But I agree with you, and I generally prefer a little bit more sophisticated designs, albeit in this study, I think we were able to do a pretty good job. And that goes to one of the points you made about multiple doses potentially being effective. And so one of the things that we found in the biomarker analyses was that once we were above the 5 milligram dose, it looked like there was a difference in how the biomarkers were manifesting. And for that reason, it was kind of unclear which would be the best dose from 5 even all the way up through 14 milligrams. And for that reason, actually into phase 2, we're taking both the 5 milligram and 14 milligram doses forward to try to study them further, because exactly to your point, if we could use the lower dose, then that would be a good thing to do. And of course, that's a huge priority of the regulatory agencies right now, the what's known as Project Optimus from the FDA. Just a sort of final comment is you made a comment about patients being involved in trial designs. And I think in early phase work, that's a little bit harder than in others, but it does remain a very important consideration. And I know from personal experience participating in some of the panels that most of the larger companies do now have patient advocates that do have a seat at the table and voice, even in the development of early phase studies. Understanding these are very rigorous studies that are frankly very inconvenient for patients, they're essential for drug development, and they do offer an opportunity to patients where treatments might otherwise not be immediately obvious. And so I would reinforce kind of what you talked about. We do need to make these as user-friendly as possible and as non-exclusionary as possible. And I think in that manner, then we can really try to optimize the experience of patients while still generating the necessary data that we need to advance the field.
The work that's going on is really important, and we need to celebrate victories, both small and large, and then get back to work to finding new biomarkers and diagnostics and therapies for the people whose tumors didn't respond. We don't want to forget about the rest of the stroma either that gets co-opted by cancer cells and usually keeps the body healthy, because the body is an integrated circuit. I come from the computer world, so that's the way I think about it. I think it's important to share that clinical trial participants and patients want their data shared and the data that's generated from them so that we can focus on more medical advances like we've heard about today. And many of us are working with oncologists and researchers as well as patient groups to make sure that everyone is updated by this information. So I'd like to thank the journals that are doing that as well. And there's a way, I think, for us to connect to more patient communities to help them understand what research can do.
Jason, Deborah, thank you so much for that lovely discussion. As we wrap up, Gil, I'm going to turn back to you to make some closing remarks on what are your key takeaways from the ESMO meeting.
Well, from my perspective, ESMO 24 has some great practice-changing trials that actually empowered many of our colleagues to return to their clinics a few days later and have new discussions with their patients about treatment options. So ultimately, these are the most impactful aspects of a Congress, and the immediate changes that we can actually implement to improve patient care are the reason that we do this. So I think Barcelona definitely delivered.
On that note, I want to thank all our panelists today for joining us, Gil, Jason, and Deborah. It's been very insightful to hear your thoughts and discussions, and I'm sure our listeners will take away a lot from it. Before we close, I would like to remind our listeners that the journal Cancer is always looking for high-quality research submissions. We've recently introduced several new features like free format submission and direct to cancer to make the submission process even easier for authors. We'll include further information about these new features in the show notes, and we encourage you to consider Cancer as the home for your next paper. Thank you for listening, and we look forward to having you join us again for future episodes of Cancer Speak.